Hello, good evening, everybody. Thank you for joining us. Tonight's topic is inflammation of the eye, what you and your rheumatologist should know. My name is Soroosh Behshad, and I am one of the cornea, cataract, and refractive surgeons at the Gavin Herbert Eye Institute. This evening, we're going to have a discussion about inflammation and the eye. So starting off, I wanted to highlight what the take-home points are from this evening's discussion. I think one of the big things here is that the eye can be involved in a number of autoimmune diseases. And then inflammation of the eye can be independent of control of a systemic autoimmune or systemic inflammation. So they always don't go hand in hand. And then on the other hand, eye inflammation can be a sign of systemic inflammation not adequately controlled. And then lastly, the big take-home point for this presentation is, a combination of eye redness, pain, change in vision. This is a triad of symptoms that should be evaluated as soon as possible by an ophthalmologist. So briefly here, just kind of highlighting the how we're going to approach this. When it comes to inflammation of the eye, it's important to be comfortable with the anatomy and know which part of the eye that the inflammation is contained in. And then the different inflammatory conditions of the eye, various systemic diseases that can cause inflammation in the eye. We'll kind of close with some treatments and potential complications of why treatment early is important. So this is, in my opinion, the most wonderful organ of the body, the eye. We can see here we've got the different anatomical parts of the eye. Right now, before we kind of dive in into this, just kind of want to separate the eye into the front of the eye. And so when we're referring to the front of the eye, we're referring to the cornea, the iris, and the lens of the eye. And then the back of the eye, that's contained, the eye is contained by a jelly called the vitreous. We have the retina and then the optic nerve that connects the eye to the brain and sends a signal of vision so that our brain can perceive it. So, what are the different types of inflammation that can happen in the eye? So here's a summary of the different types of inflammation that can happen, and we're going to go into depth a little bit more, and then kind of connect this with the anatomy of the eye to kind of help better understand what these terms mean. So first off, there is an entity as scleritis or episcleritis. And so when we're talking about the sclera, we're talking about the white connective tissue that's underneath the conjunctiva. The conjunctiva is actually a clear layer of the eye. And so when we're looking at the white of the eye, we're actually looking through the conjunctiva at the sclera. The inflammation of the sclera itself is referred to as scleritis, and then inflammation just above the sclera, so underneath the conjunctiva, is referred to as episcleritis. And although they sound similar, and the anatomy is very close, they're very different in terms of both presentation and treatment. Um, we have to also kind of correlate this with the body because it's very easy for people when they've got an autoimmune condition like rheumatoid arthritis to understand that they tend to have inflammation of, for example, their joints. Well, this is kind of a similar thing when it comes to scleritis and episcleritis. So it is the inflammation of the wall of the eye, but what's interesting is that tissue is actually the same. It's made up of collagen, what we find in our joints and bones. So, common symptoms of when we think of autoimmune conditions causing arthritis. So episcleritis, and if you remember on our little anatomy slide, that was just above the sclera, but underneath the conjunctiva. So it's a superficial layer of the eye. And commonly, patients will present with a red eye, kind of shown in this picture here. Generally, it's not painful, so it looks worse than it feels, and it's usually self-limited, so either like a quadrant or half of the white of the eye. And in most situations, this will go away on its own, even without treatment. Now, scleritis is a different entity. So this is inflammation of the actual sclera, the deeper layer of the wall of the eye. So not only do we have that eye redness, it is very painful. And then as it progresses, it can cause vision changes, not always. And this commonly we need to treat systemically and lower the immune response of the body towards basically the sclera. And so if our patients do have an autoimmune condition, getting that better controlled, and if not, maybe working them up to see this might be their initial presentation of an autoimmune condition. Now, kind of getting into the scarier stuff, we have necrotizing scleritis. And so, continued inflammation of the wall of the eye can lead to necrosis, which is basically weakening and thinning of the wall of the eye. And so here you can see on the image of the left, this is scleral necrosis. So there's a lot of blood vessels around this area, but there's no blood flow to this area of the sclera. So it's basically dead tissue. It's commonly a sign of very poorly controlled systemic an inflammatory condition. More common with patients with uncontrolled rheumatoid arthritis and severe inflammation, we can actually get an entity called scleromalacia perforans, where basically the sclera gets so thin that the inside of the eye starts to protrude through those thin areas, and potential trauma in this area can lead to a perforation. So once again, highlighting of why it's important that our patients who have autoimmune conditions, not only are their conditions controlled, but if they have any sort of eye symptoms, come in for an eye exam relatively quickly. Moving on to the next entity, that would be orbitopathy. So this is basically the inflammation involving the orbit. So this is the surrounding tissue of the eye. So if you look at this image here, this eye on the right side of the image, basically there's a lot of swelling and inflammation of the orbit. When compared to the other orbit, you can see we just have the optic nerve in the center and the muscles, not much inflammation. And so inflammation can actually involve around the eye. And then, with this, the inflammation surrounding the eye can lead to more specific symptoms of double vision because the eye actually becomes misaligned with the eye that's not affected. We can get eye bulging, or a medical term for that is proptosis, as well as the pain, swelling, and then definitely vision loss as well can go with this. The next entity is optic neuritis, so basically inflammation of the optic nerve. And as we discussed, the optic nerve is what connects the eye to the brain. And so this is how the signal is transferred to our brain so we can perceive images. So if there's inflammation, it's definitely going to affect our vision. So with optic neuritis, there is commonly a decrease or loss of vision, but more commonly a loss of color or contrast perception, so decrease contrast in vision. And so with this, we want to treat it pretty aggressively, and systemic treatments with high-dose steroids and other immunomodulators can be helpful. Once again, highlighting of why it's important to come in and get checked, because the sooner treatment is enacted, the higher the chance we can prevent long-term vision effects. So here on the bottom left, you can see this is a normal optic nerve. So the vessels that are coming out through the optic nerve are going out into the retina. We've got a small cup here. And so this is a normal optic nerve. In the larger picture, you can see it's really hard to see the edges and the borders of this optic nerve. And we actually are starting to lose kind of where those blood vessels are coming in and out. And so this is actually optic neuritis. The optic nerve is swollen from inflammation. And just to show you here, this is a visual field of a patient who has optic neuritis. And so the darker areas are actually not good. That means those were areas that they missed. So they're basically having multiple areas where they're missing vision. And so in this patient, treatment was enacted with steroids, and then a visual field was then done after, and their visual field is almost normal. This large black circular area is the normal blind spot of the eye, and you can see the other areas that were dark have resolved. So once again, showing you again the potential improvement we can have if we start treatment early. Now, my favorite part of the eye that can also have inflammation is the cornea, and we refer to this as keratitis. One of the common inflammatory corneal conditions is peripheral ulcerative keratitis. And so this is inflammation of the cornea, or the clear part of the eye. So when you're looking at someone, you're actually looking through their cornea, which is clear, and then you can see their iris and their pupil. And so normally there is no immune system in the cornea, but what can happen is that the immune system is reacting, or there's an autoimmune condition. The immune system can start inflammation in the peripheral parts of the cornea. You can see here these edges where there's whitening of the cornea. And because the immune system is not exposed to the cornea, the common response is that the immune system actually starts attacking the cornea and causing it to thin, which can lead to issues. And so with this, symptoms can be mild of just some irritation to actual pain, and then as it progresses, vision changes as that gets worse. And if it's not treated, it can actually lead to a rupture of the cornea. And just showing you here, this is a cornea of a patient. You can see these vessels. This is the peripheral inflammation that's progressed into the cornea, cause thinning of this portion of the cornea, and then actually the iris from the inside of the eye has actually plugged that area. So once again, this is a perforation, which is technically an emergency that we need to surgically kind of manage. So upper left is another case where there is thinning of this peripheral cornea, and the iris has actually protruded through that opening and plugged it. And so we proceeded with a emergent corneal and scleral transplant. So you can see here, this circular tissue is from a donor. Some of the sclera and the cornea were transplanted and stitched in place to kind of reform the eye and bring back vision for this patient. Now, moving on deeper into the front of the eye, the anterior chamber, if you have inflammation in the front of the eye, we refer to that as anterior uveitis. If we get inflammation of the back of the eye, whether that's the jelly, the vitreous, or the choroid or the retina, which are the inner layers of the eye, then we consider that posterior uveitis. Uveitis is a common presentation of patients to the eye clinic. And one eye happening randomly could just be a normal kind of thing that just happened and once treated will not come back. However, cases where it presents both eyes at the same time, or it continues to come back, that's where we become suspicious that if our patients have not been worked up to kind of work them up for a potential autoimmune condition. And so this inflammation of the eye commonly presents with pain, redness, light sensitivity, could be potentially new floaters. So not our normal like one or two floaters that kind of come and go, or like an additional floater we get every now and then, but like hundreds of new floaters in our vision, and then decreased vision or blurriness. So this is an autoimmune condition called Behçet's that is commonly associated with uveitis. And just showing you some pictures, this patient, has had multiple bouts of inflammation. So you can see their iris has actually scarred down to the pupil, and so their pupil is irregular. And here on the right side, when they're active and their eye is inflamed, there's a lot of inflammatory cells in the front of the eye. So it's kind of smoky if you're trying to look into the eye. And at the bottom, you can see this kind of whitish entity that we call a hypopyon. And so when the immune cells are so increased in the front of the eye, they actually over time, gravity pulls them down and they deposit, and we can kind of get this whitening of the inner part of the eye. And so this could be a sign of inflammation in the front of the eye. If there's an infection going on, it could also be associated with an infection of the eye. And so once again, uveitis can lead to vision loss. Chronic uveitis can lead to cataracts. Chronic inflammation with the uveitis can lead to other entities like glaucoma. And commonly our treatment, we treat it with steroids. So we have eye drop steroids, we have injections, and also oral steroids, and then dilating drops. And if we don't know if the patient has autoimmune condition, working them up for that, and then working with the rheumatologist to get their immune system better controlled. And so on the uveitis side of things, we have inflammation of the retina, so retinal vasculitis, which is basically inflammation of the blood vessels of the retina. And so this is a kind of a bigger effect to the vision. So decreased vision, or missing a whole quadrant or half of the vision. And once again, not like one floater, but all of a sudden hundreds of new floaters like pepper in our patient's field of view. And treatment here, although we do have lots of topical and injectable medications, uh, usually systemic medications work better, and likely more immunosuppressive medication. And then when there's chronic inflammation of the retina, that inflammation can lead to a risk of a retinal detachment. And so in many cases, a retinal laser can be applied to help prevent that retinal detachment from occurring and causing our patients to lose further vision. So with Behçet's here, this is a retinal vasculitis that can be correlated with this. And so actually you can see kind of the whitening of the top half of the retina here. You can see at the bottom of the screen, the retina is very kind of like a orangish red hue to it. That's like the blood flow. But then you can kind of see this chalky color in the top. That's because there's been a retinal artery that's been blocked from due to inflammation. And so it's basically almost like a stroke of the retina, where this part of the retina is not getting blood flow and basically dying. This is IV angiography that we can do in the eye clinic where we inject a dye in the veins and then kind of take photos of it when it gets to the retina. So you can see here, this is both eyes here, and we have our normal vasculature, but out in the periphery, you can see these area where there's leakage. So there's inflammation in this area, and these blood vessels are leaking inflammatory components in the back of the eye. And then just showing how difficult this can be to treat. In many of these conditions, there is kind of a decrease in blood flow. So then the retina starts releasing signals of, to increase and make more blood vessels. But the problem is those new blood vessels are more leaky and cause a problem to get worse. And so sometimes a retina specialist may apply laser. So this is that same patient after they've received some laser in their peripheral retina to kill those retinal cells that don't really help with our vision, but to stop releasing those mediators that kind of are saying that they're not getting blood flow and causing these new blood vessels to form that are causing the problem to get worse. But you can see in this condition, even after doing the laser, there's still leakage. You can see those areas of darkening and pooling of the dye there. So moving on kind of on the same age, what are the conditions systemic conditions that can go with these types of vasculitides? So we have granulomatosis and polyangiitis, or GPA, Behçet's, polyarteritis nodosa, giant cell arteritis, rheumatoid vasculitis, and Takayasu's arteritis. So these are systemic conditions that commonly have inflammation associated with the eye and commonly the vessels of the back of the eye. So with GPA, about 40% of patients with this condition will have some sort of eye disease. And interestingly, and the literature rates anywhere between 8 to 16% of these patients actually will be diagnosed with GPA because of presenting with an eye condition. And so just kind of showing here, there's a full gamut. We can get the orbitopathy, we can get the optic neuritis, we can get anterior uveitis. So just multiple ways that this condition can present in the eye. You can see here looking at the literature, commonly episcleritis or scleritis, as well as orbitopathy are kind of high up there. But once again, they can end up with inflammation of the cornea, the front of the eye, the back of the eye, and the optic nerve. And so in these patients, if this condition is not controlled, there is a risk for vision loss. It could be just a little bit too complete. And this is higher in patients that have optic nerve involvement. Once again, the importance of why we need to treat this very quickly. And so trying to treat this locally in the eye usually does not lead to success. So working on systemic conditions and working with the rheumatologist to get the inflammation on the under control is usually the key to get this treated. With Behçet's, the range is it's higher, but it's about 43 to 72% of patients with Behçet's that will have eye symptoms and issues as well. And about a fourth of patients have some sort of vision loss. So once again, important why it's good to have regular eye exams with these conditions. And with Behçet's, you can get uveitis, retinal vasculitis, and optic neuropathy. Another condition, PAN, about 10 to 20% of these these patients will have some sort of eye manifestations. And it can be anywhere from episcleritis to scleritis, uveitis, retinal vasculitis, optic neuropathy, and orbitopathy. Giant cell arteritis, which is another condition, which is an inflammation of the large vessels. And so with this entity, this is something that can lead to vision loss that can be permanent. So we want to diagnose this early. And so the eyes can be involved in about 14 to 70% of these patients. The literature is all over the place, but you can see here definitely eye symptoms can be one of the signs of this. And the kind of concern here is if the inflammation progresses to the optic nerve, that's where we can actually get permanent vision loss. So we want to catch this early and get these patients treated by the rheumatologist as soon as possible. So this is an image of the back of the eye of the retina. We have the optic nerve here. Once again, the vessels coming out, our macula here is this darker area. So this is a normal retina. And then this is a patient with ischemic optic neuropathy due to giant cell arteritis. Basically, they've had an occlusive episode of the artery that provides blood to the eye and the optic nerve. And so this is something that can lead to permanent vision loss. Now, a common autoimmune condition, rheumatoid arthritis. The most common eye condition with this is dry eye. And so a dry eye sounds like a simple condition, like, oh, just use some artificial tears. But when it's inflammatory, it leads to this cycle where inflammation leads to dryness, which causes the inflammation to get worse, which causes the dryness to get worse. And so this is something we want to treat pretty aggressively in patients that have autoimmune causes here. We do have a separate lecture on dry eye and treatments that we kind of go into this a little bit more. But once again, rheumatoid arthritis is a pretty common condition. So just highlighting that dry eye is a common eye correlation with that. Scleritis and episcleritis, the most common causes of that are usually rheumatoid arthritis as well as a keratitis. We discussed that kind of scary picture with scleritis. If the immune system in these patients is not controlled and it continues to progress and is not treated, it can lead to a necrotizing scleritis that can turn into an emergency, which can lead to permanent vision loss. Once again, so this is a patient with scleritis. And here's another patient just kind of showing you with their eye in the different conditions. You can see the redness, the dilation of these vessels, and this patient actually has a lot of symptoms and pain, light sensitivity. And then after that same patient, after treatment with IV steroids, you can see their eye is basically quieted down, less inflammation, and they don't have, the same symptoms of pain and sensitivity anymore. So once again, if we can enact the treatments, we can really prevent vision loss and, obviously resolve many of the symptoms related to these systemic conditions. Now, when it comes to dry eye, we kind of touched on that. There's a whole gamut of different treatments. We have, artificial tears, we have punctal plugs, we have different procedures and surgeries, and really the medications that have become available in the last few years. It's just been amazing. We're getting more and more newer medications that work really well at targeting specific types of dry eye. And once again, we've kind of hit this pretty hard, but our patients with rheumatic diseases, it also not only does the autoimmune condition itself cause inflammatory dry eye, but sometimes it's a symptom of the medications that many of these patients are taking. And so, starting these patients on dry eye medications usually is a first go over trying to use some of the over-the-counter drops, just because many of these medications target inflammation that is causing the dryness. When it comes to the treatment of ocular inflammation, we have local treatments that we can provide within the eye, whether it's topical drops or injections, as well as systemic therapies that we can work hand in hand with the rheumatologist to kind of better control the systemic inflammation. We kind of talked about different scenarios where local treatment can be helpful versus others where it's definitely the systemic treatments that need to be enacted. So when it comes to kind of more of the emergencies, things like scleritis, when it's non-necrotizing, commonly just oral NSAIDs, so things like high-dose ibuprofen or steroids can really help control this and take care of it. Now, if it goes, continues and it's not treated, then we can kind of get the necrotizing form, and that's where a surgical emergency can happen. So in conclusion, systemic vasculitis can manifest as inflammation of the eye, and that inflammation is what can lead to loss of vision. Um, and the inflammation in the eye may be independent of how well the systemic disease is doing. So once again, working with the rheumatologist to just make sure patients that have these autoimmune conditions know when to come in for an eye exam. And the triad of the red, painful eyes and change in vision in a patient who's got an autoimmune condition, these are very important signs of getting in as soon as possible for an eye exam, and in some cases, potentially even the emergency room if it's over a weekend or something. So just kind of wrapping this up, at GHEI, we have many ophthalmologists, and most of us are subspecialty trained. So here are some of my colleagues and myself that we focus on the front of the eye. So, basic eye exams as well as inflammation contained to the front of the eye. And actually, we have further subspecialists. We have two ophthalmologists, Dr. Olivia Lee and Dr. Sanjay Kadar, who are not only cornea specialists, but they are also subspecialized in uveitis or the inflammation of the eye. And so they are experts when it comes to inflammation of the eye. And a big thank you to Dr. Kadar for his help with this evening's presentation. And then lastly, when it comes to some of the retinal vasculitis, we do have multiple retina specialists that all are well aware of treating retinal inflammatory conditions, as well as neuro-ophthalmologists who do deal with treatment of optic nerve inflammation. So that being said, that concludes my prepared presentation with the slides. Thank you, everybody.